This is the last group of bacteria we'll cover in this class before moving on to viruses. And so this group is the Chlamydiaceae. Just like Rickettsia, they are obligate intracellular parasites. They are very, very small. They can pass through those 0.45 micron filters. They were originally thought, again, to be viruses because they were so small, but it turns out they are bacteria. They are organized like gram-negative, so they have the two membranes and the thin layer of peptidoglycan. But the reason that I say organized like instead of saying they are gram-negative is that the Chlamydiaceae have a really interesting or unique developmental cycle. There are very few other bacteria that we know of that cause human disease that do something similar. With the Chlamydiaceae, what we're looking at are two forms of the bacterium. There are elementary bodies, which you are free to abbreviate as EB. These are metabolically inactive, so they're not doing any sort of growth or replication, but they are infectious. So they're kind of a dormant little packet of infection. Once the bacteria, the especially elementary body stage, has gotten into the host cell, they will differentiate into what are called reticulate bodies, or you could abbreviate them RB. These are metabolically active. These are the replicating stage of the bacterium, but they are non-infectious, so they're not capable of binding host cells to be internalized. The elementary bodies are resistant to harsh environmental factors. Because they're not actively growing and replicating, because they've kind of reorganized themselves to be more transmissible, it's just a little bit harder to get rid of them. These, in this particular stage, may not even have peptidoglycan. So then you can think about what are the implications for antibiotic therapy if we don't have peptidoglycan. All members of the Chlamydiaceae have major outer membrane proteins. Each species has a different major outer membrane protein, and slight variations can lead to different serovars of the same species. A particular outer membrane protein called outer membrane protein 2 is what helps to provide some of that stability to the EBs, even when they don't have peptidoglycan. All members of the Chlamydiaceae are energy parasites. They are not able to synthesize their own ATP. So the only way that they can get ATP for their own cellular functions is to steal it from the host. What we're looking at in this diagram is the stages of infection of the Chlamydiaceae. The elementary bodies will attach to a susceptible cell and be internalized. Inside the phagosome, the elementary bodies will reorganize into the reticulate bodies. They will continue to grow. Some of the reticulate bodies will then turn themselves back into elementary bodies, and some of the other reticulate bodies will continue to reproduce. And what you'll end up seeing, let's say you were looking at this under a microscope, is this giant inclusion that contains a mix of elementary bodies and reticulate bodies. Continued reorganization, continued replication, and then eventually you get the extrusion of this big ball of elementary bodies that are then able to continue to cause infection. And this process from attachment to extrusion takes about 72 hours. The first chlamydia species we'll talk about is Chlamydia trachomatis, and this is the causative agent of chlamydia. So serovars A, B, BA, and C cause trachoma, which is an eye infection. D through K cause the classic presentation of urogenital disease. And then these L serovars cause a more severe or significant form of disease called lymphogranuloma venereum. All of these elementary bodies can bind to lots of different kinds of cells that are in mucous membranes, including cells of the urethra, endocervix, endometrium, fallopian tubes, anal rectum, respiratory tract, and conjunctivae. What happens with these LGV, that's the abbreviation for lymphogranuloma venereum, serovars, is they're more invasive, whereas trachoma and the standard urogenital tract disease tend to kind of stay where they are, either in the eyes or in the genital tract. These LGV serovars tend to penetrate more deeply into the body, and that's because they can replicate inside of mononuclear phagocytes. So they're transported around the body, especially to lymph nodes. The symptoms of chlamydia are caused by destruction of host cells and the pro-inflammatory cytokines that are produced. The lymphogranuloma venereum, the LGV serovars, lead to lesions in the lymph nodes. And that's kind of what you're shown here. You've got infected lymph nodes, and then you have a very swollen vulva caused by the inability of the lymph nodes to drain. Lesions, especially in the lymph nodes, can become necrotic in our LGV serovars and spread and have further tissue destruction. The non-LGV serovars tend to lead to a severe inflammatory response, which can help keep the infection more localized to where it is, and then also cause the symptoms and signs that will allow a patient to seek treatment. Unfortunately, infection does not give immunity. Instead, we have this really interesting immune response to a secondary infection where generally, when you think about, I've had an infection, I cleared it, now I have a second infection, I should be able to clear it faster. What tends to happen here is that in a secondary infection or a secondary exposure, the immune response is so enhanced that the inflammatory response causes more damage and more symptoms. Some of the symptoms can include things like vision loss. So if you have the trachoma serovars, sterility, and sexual dysfunction. We also worry about chlamydia infection if a newborn or neonate is born to a mother who has chlamydia. 10 to 20% of exposed newborns can develop pneumonia if they get the bacterium in their respiratory tract during delivery. Chlamydia itself is the most common bacterial sexually transmitted infection, and it is the most common reportable infection in the United States. There were over 1.8 million reported infections in 2019. It is estimated that that is an underreporting of the true number of cases. So it's estimated that there are actually closer to 3 million cases per year in the US. These are mostly caused by serovars D through K. We don't tend to see a lot of trachoma or chlamydia infection in the eye in the US. We tend to see a lot more of just the standard urogenital chlamydia infection. The LGV serovars are more common in other parts of the world, including Africa, Asia, and South America. And with the LGV serovars, men tend to have symptomatic infection more commonly than women, and that's a little bit unique. In the US, we see chlamydia incidence at high rates, kind of just like all the other sexually transmitted infections. So here's Fresno County with some of the highest rates in California. And then, of course, the Southeast tends to have pretty high rates as well. And then this is a headline from the New York Times a few years ago, a reason to stay home on Saturday night. More than 100 million Americans have an STD, researchers have found. So that's 1/3 of the population. And then it lists that some of the bacterial ones are definitely on the rise. So Chlamydia trachomatis, again, trachoma is a chronic disease of the eyes. Follicular conjunctivitis is the first symptom. So again, pink eye. Conjunctivitis is pink eye. What can happen is that chronic inflammation can lead to scarring, and this is going to sound really gross, but the scarring can cause the eyelids to invert, forcing the eyelashes to actually like touch the eye, and the eyelashes can abrade the cornea, scratch the cornea over and over and over and over again, and eventually lead to blindness. So one of the things about Chlamydia trachomatis is that just because the serovars D through K are most commonly associated with urogenital infection, it doesn't mean that they can't cause eye infection or trachoma as well. So these serovars can also cause adult inclusion conjunctivitis. This is where you're going to have a mucopurulent discharge, so like a white discharge, like pus basically. And it can again also cause corneal scarring, but it's not the same as the eyelash abrasion. Neonates can also get trachoma or conjunctivitis. This is if they're born to an infected mother. It will have significant complications for their eyesight, so eyelid swelling and copious discharge. Another issue is that if left untreated, or if only treated topically, like perhaps with some sort of antibiotic ointment, the bacteria can cause pneumonia. The infection is acquired during childbirth, and approximately 25% of children born to mothers with active genital infections will develop the neonatal conjunctivitis. So here's a picture of the stages of trachoma. So it's kind of gross, I apologize. But you see the inversion of the eyelid. Well, so here you see the swelling right underneath the eyelid. And then here you have the inversion, and you can see how the eyelashes scrape the cornea. And then this is a patient who has gone completely blind from it. The bacteria, again, can cause infant pneumonia. This would show up approximately 2 to 3 weeks after birth. They'll have kind of the runny nose and a distinctive staccato cough. If you've ever done band, you know staccato is like short, like rapid sounds. Again, most importantly are the urogenital infections, or I guess most commonly. 80% of women tend to be asymptomatic, which makes women, in this case, an important reservoir for spread. The early symptom would be discharge, and what you're looking at here is a cervix, and you can see the discharge coming from the cervix. This is a case study of 2 infant girls who developed pneumonia from Chlamydia trachomatis. The first infant was born by vaginal delivery at 39 weeks gestation. The second infant was born by cesarean at 40 weeks. The infants were in good condition until fever and a rapid breathing developed at 3 and 13 days respectively. So the child born by vaginal delivery developed symptoms at 3 days. The child born by C-section developed symptoms at 13 days. And for those of you who are not aware, 39 weeks is not considered premature. 39 weeks is considered a full-term birth. So these are both full-term infants. Chest x-ray showed infiltrates in the whole lungs. Cultures of blood, urine, throat, feces, cerebrospinal fluid were all negative, but antigen tests for Chlamydia trachomatis were positive from conjunctival, so eye, and nasopharyngeal swabs. These cases illustrate the presentation of pneumonia in infants infected with Chlamydia trachomatis at or near birth, although the characteristic staccato cough was not described. Just because it wasn't described doesn't mean it didn't happen, it just wasn't written up in this particular case study. So one of the things to think about is we often think about, well, if a child is born by C-section and they don't pass through the vaginal canal, then they're not at risk for developing the disease. But as we see in this case, even a child born by C-section could be at risk of chlamydia if the mother is infected, because this bacterium can replicate in all of those mucous membranes in the tissues of the fallopian tubes, etc. So with chlamydia infection, approximately 75% of men are symptomatic, so they're most often going to be the ones to seek treatment. But in men, it can lead to what's called Reiter syndrome, which is inflammation in the urethra, the conjunctiva, polyarthritis, and mucocutaneous lesions. With chlamydia, another thing that's really common is to see a co-infection with gonorrhea. And so sometimes what we'll see is that a patient will present and be easily diagnosed with gonorrhea. Think about why it's so easy to diagnose gonorrhea. Will not be diagnosed with chlamydia. So they'll be prescribed something like penicillin to help clear up the gonorrhea. And then the patient is like, why did my symptoms not go away? And it turns out, well, they still have chlamydia. And so a second antibiotic has to be given, not penicillin. So here's Reiter syndrome. A 30-year-old man presented to a university hospital with complaints of painful urination for a 3-year duration. So this guy was suffering for a really long time. He had penile inflammation, joint swelling, and fever. Skin lesions and nail changes were noted. High levels of chlamydia antibodies were present, but antigen tests and nucleic acid amplification tests of urethral exudates and conjunctiva were negative for Chlamydia trachomatis. A diagnosis of Reiter syndrome was made, and treatment with ofloxacin was initiated. Complete remission of skin lesions and urethral symptoms was achieved. The patient's wife was also admitted to the hospital with a history of 2 years of lower abdominal pain and vaginal bleeding and discharge. Diagnosis of pelvic inflammatory disease was made, and Chlamydia trachomatis infection was confirmed by positive cervical and urethral antigen tests. The vaginal smear was also positive for Trichomonas vaginalis, and we'll talk about that one as we talk about the parasites. These patients illustrate 2 potential complications of Chlamydia trachomatis urogenital infections, Reiter syndrome, and pelvic inflammatory disease. With the LGV serovars, there will be a small painless lesion that can appear 1 to 4 weeks after infection. But as the infection progresses, the second stage of infection has inflammation and swelling, including the formation of buboes that can rupture. And remember, we talked about buboes when we talked about bubonic plague. There are these infected lymph nodes that just have a lot of bacteria in them, start to get tissue necrosis, and so you get a lot of issues there. Women infected with the LGV serovars can often experience proctitis, inflammation of the anus and rectum. It's not uncommon in men, though, either. Untreated LGV infections can resolve or lead to chronic ulceration. And I think I showed you a picture where we saw the swelling of the vulva. That's basically what elephantiasis is. So elephantiasis is where you start to get swelling of an extremity because of damage to the lymph nodes and damage to the draining that we would see in the lymphatic system. So when the lymphatic system can't drain fluid, that fluid is retained in the extremity and causes significant swelling. Chlamydia infections are diagnosed based on microscopy, serology, culture, nucleic acid, lots of different tests. The nucleic acid tests are the best and most sensitive for diagnosing the infection. Antibiotic treatment works. We don't see really much antibiotic resistance. Doxycycline is the drug of choice for adults, but erythromycin would be prescribed for children or pregnant women. Again, not penicillin. So think about why not penicillin. There's going to be a couple of different reasons. Prevention is difficult. We don't have a vaccine available. So I guess I say prevention is difficult, but not really. Safe sex practices, prompt treatment of symptomatic patients and their partners.